Welcome to today's lecture on infection control in operative dentistry. In this session, we'll cover essential topics to help you maintain a sterile and safe dental environment. First, we'll discuss exposure risks, followed by the importance of airborne contamination control. We'll then look at direct versus indirect contamination and the significance of immunization against hepatitis. Personal barrier protection and having an effective exposure incident plan are crucial. We'll guide you through these. Next, we'll cover aseptic techniques, ultrasonic cleaning, and various methods of sterilization to ensure instrument cleanliness. Finally, we'll discuss methods to address prion and their specific challenges. Stay tuned as we equip you with the knowledge to uphold high standards of infection control in operative dentistry. Let's get started. Exposure risks and effect of infections on dentistry. Overview. Significant increase in serious transmissible diseases has created global concern. This has affected the treatment approaches of healthcare practitioners, especially in dentistry. The goal is to ensure compliance with standard precautions and other methods to minimize infection risks. Airborne contamination. Dental procedures often create airborne contaminants. Sources include dental unit water spray system, microbial contaminants from saliva, tissues, blood, plaque, and debris from carious teeth. Types of airborne contaminants. Aerosols. Size, invisible particles ranging from 5 m to approximately 50 m suspension, can remain in the air and be inhaled for hours. Risks, may carry agents of respiratory infections. Mists. Size, visible and light, consisting of droplets around 50 m duration, heavy mists settle gradually from the air after 5 to 15 minutes. Risks, can transmit infections like tuberculosis when produced by a patient with active pulmonary or pharyngeal tuberculosis. Spatter. Size, particles generally larger than 50 m, visible as splashes. Trajectory, falls within 3 feet of the patient's mouth, potentially coating the face and outer garments of dental personnel. Risks, potential route for blood-borne pathogen infection through mucosal splashes. Infection control measures. Personal protective equipment, PPE. Standard requirements. Masks. Protective eyewear. Gloves. Gowns. Additional measures. Pre-treatment mouth rinse, reduces microbial load in the patient's. Rubber dam, isolates the treatment area and reduces exposure to contaminants. High-velocity air evacuation, helps in removing airborne particles quickly. Adequate air circulation, ensures that airborne particles do not remain suspended for long periods, reducing the risk of respiratory infection. Conclusion. Effective infection control in dentistry involves multiple strategies, including the use of PPE, specific dental equipment, and maintaining good air circulation. These measures are crucial in minimizing the risk of transmitting infections in a dental setting. Direct versus indirect contamination. Direct contamination. Definition, occurs through direct contact with bodily fluids. Exposure concern, major exposure concern for dental personnel. Examples, contact with blood, saliva, or other bodily fluids during dental procedures. Indirect contamination. Definition, occurs due to saliva-contaminated hands, leading to contact with various surfaces. Exposure scenario, dentist and assistant repeatedly handle or contact unprotected operatory surfaces during treatment. Examples of contaminated areas. Handpieces, air-water syringe handles. Control switches on the patient's chair. Seat edges and rests of the dentist's and assistant's chairs. Knobs. Cabinet, drawer, and operatory tray handles. Room light switches. Operatory telephones. Preventative measures. Barrier protection, use of barriers for personnel and equipment. Instrument sterilization, ensuring all instruments are properly sterilized. Avoiding direct contact, using methods to avoid direct contact with various surfaces during treatment. Immunization against hepatitis A, B, and C viruses. Hepatitis A virus, HAV. An effective vaccine against HAV is available and recommended for dentists, dental students, and auxiliary personnel. Hepatitis B virus, HBV. HBV vaccine involves 3 doses, one initial dose, a second dose 1 month later, and a third dose 6 months after the first. The vaccine is administered in the arm. Protection is nearly 100% for individuals who develop antibodies. Follow-up testing is recommended by the CDC to confirm immunity 1 month after completing immunization. Hepatitis C virus, HCV. No vaccine is currently available for HCV. Rapid mutation of the virus in infected individuals poses challenges for vaccine development. No protective immunoglobulin is available for exposed individuals. Tests for hepatitis B antibody and boosters. Dental personnel should undergo testing 1 to 6 months after completing HBV vaccination to determine if protective anti-HBs antibodies were formed. Approximately 1 in 30 vaccinated adults under 40 and higher percentages of those over 40 may not respond adequately to the vaccine. Routine boosters are not generally recommended for the healthcare profession by the CDC. Testing for anti-HBs antibodies, with a serum ratio below 10 units, may prompt a booster dose of the HBV antigen. In dentistry, due to exposure risks and uncertainties, individuals may prefer testing for HBs antibodies to check immunity. Serologic tests related to hepatitis B viruses. HBsAg testing detects HBV surface antigen, HBsAg, in the blood. Indicates active infection, regardless of symptoms. HBAg testing identifies HBV antigen, HE, associated with high viral concentrations and infectiousness. Antibody testing. Anti-HBC testing detects antibodies against HBV core antigen. Positive after a few months, indicating past infection, non-protective. Anti-HBs testing identifies antibodies against HBV surface antigen. Positive results indicate recovery from infection or successful immunization, protective. Key points. HBsAg signals ongoing infection. HBAg provides insights into transmission risk. HBC signifies past infection but not protection. Anti-HBs indicates recovery or successful immunization, protection. Serologic tests related to hepatitis C viruses. Hepatitis C virus, HCV, testing. Anti-HCV antibody test detects antibodies to hepatitis C virus in the blood. Positive result indicates exposure but doesn't differentiate between current and resolved infections. HCV RNA testing, nucleic acid testing directly detects the presence of HCV RNA in the blood. Confirms active infection. Used to determine the viral load. Key points. Anti-HCV antibody test reveals exposure. Distinguish between current and resolved infections. HCV RNA testing confirms active infection and determines viral load. Handwashing protocol for clinicians. Preparation. Remove wristwatch, jewelry, and rings. Cleanser selection. Use a suitable cleanser for handwashing. Prefer hand cleansers with mild antiseptics like 3% perchlorometaxyl, PCMX, or chlorhexidine. 4% chlorhexidine may be used for special cleansing needs. Rationale for antiseptics. Controls transient pathogens. Suppresses overgrowth of skin bacteria. Operatory clothing and overgarment guidelines for infection control. Contamination awareness. Operatory clothing can be heavily spattered with invisible saliva and traces of blood throughout the day. Microbial persistence. HBV and various microbes can survive on dry materials for 1 or more days. Purpose of overgarment. An overgarment should protect both clothing and skin. Recommended overgarment design. A simple, lightweight garment covering the arms, chest up to the neck, and lap when seated may offer sufficient protection. Material selection. Cloth made of cotton or cotton, synthetic fiber similar to isolation garment material may provide adequate protection against spatter. Laundering guidelines. Launder with a regular cycle and regular laundry detergent following manufacturer's directions. Use hot 70 degrees Celsius or 158 degrees Fahrenheit. For additional antimicrobial action, use cool water containing 50 to 150 ppm of chlorine from liquid laundry bleach. To make a 50 ppm chlorine solution in 5 liters of water using 3% bleach, you would need approximately 0.33 milliliters of 3% bleach. Add this amount to 5 liters of water and mix thoroughly to achieve the desired concentration. Glove usage and care guidelines for clinical personnel. 1. Glove usage. All clinical personnel must wear treatment gloves during procedures. Gloves must not be used for more than one patient. 2. Glove change protocol. After each appointment or if a leak is detected, gloves should be removed. Hands are washed, and fresh gloves are donned. 3. Disposable gloves. Inexpensive, disposable, well-fitting gloves are recommended for chairside use. 4. Glove washing prohibition. Gloves must not be washed to maintain their integrity. Washing increases vulnerability. 5. Preventing contamination. Instead of washing gloved hands, use tongs, a paper towel, or a food handler's over glove to handle items near the operatory. 6. FDA regulations. FDA allows a leak rate of less than 4% in water tests. Some companies set higher standards at less than 2% to 3%. 7. Glove storage. Store glove boxes away from sunlight. Multiple boxes should be stored in tightly closed, heavy plastic bags to minimize oxidation. Eyewear safety and maintenance protocols. Eyewear design. Consist of glasses with solid side shields for comprehensive eye protection. Cleaning and disinfection. Eyewear should be regularly cleaned and disinfected to maintain hygiene. Availability of replacement eyewear. Ensure that clean replacement eyewear is readily available while used eyewear is undergoing disinfection, optimizing time efficiency. Hair protection and hygiene guidelines for operatory personnel. Surgical cap requirement. Wear a surgical cap to protect hair. Hair management in the treatment field. Keep hair out of the treatment field to prevent contamination. Rationale for hair protection. Hair can trap heavy contamination, and if not washed away, it may be transferred back onto the face, especially when in contact with a pillow at night. Needle disposal guidelines for safety and compliance. Needle disposal container requirements. Dispose of needles in a hard-walled, leak-proof, and sealable container. The container should bear the OSHA biohazard label. Proximity of needle disposal container. Place the needle disposal container in the operatory, close to where the needle will be used. Safe handling to prevent accidents. Avoid carrying unsheathed contaminated needles or containers in a manner that could endanger others or lead to accidental spills. Compliance with local regulations. Follow local regulations for the disposal of the needle disposal container. Safe handling of handpieces and burrs. Removal of burrs after procedures. Burrs should be removed from handpieces when the procedure is finished. Orientation in hangers. If left in the handpiece in a hanger, ensure that the burr is pointed away from the hands and body. Use of special hangers. Hanging handpieces upside down in specific types of hangers can angle the burr away from the operator. Exposure Incident Plan. 1. Immediate Response Protocol. Rapid and thorough cleaning of wounds or washing of splashed eyes or mouth is crucial for minimizing infection risks. Identify specific staff members to provide assistance, direction, or transportation for medical care. Form a brief written plan for accessing rapid medical attention, constituting the initial part of the exposure incident plan. 2. Patient consent for medical history. Obtain written permission from the source patient for copying and conveying medical history to the attending physician. Knowledge of risk behavior, blood test results, or pertinent information may be conveyed verbally with permission. Comply with local laws governing patient information disclosure. 3. OSHA compliance and documentation. Information dissemination. Distribute exposure incident plan copies to employees, explaining its contents. Documentation. Document exposure route and circumstances. Identify the source patient if possible. Support. Provide and cover costs for exposure incident evaluation and follow-up evaluations for affected employees, meeting OSHA requirements. 4. Testing and prophylaxis procedures. Source patient identification. Identify and contact the source patient if possible. Obtain for testing unless the infection status is known. Blood testing. Conduct blood tests for HIV or HBV infection in the source individual as soon as possible. Provide the results confidentially to the exposed employee. Employee testing. Test the exposed employee's blood with PIN. If consent for HIV testing is not given, retain blood samples for 90 days. Post-exposure prophylaxis, PEP. Administer PEP to the employee when medically indicated. Follow U.S. Public Health Service recommendations for post-exposure prophylaxis. 5. Communication with attending physician. Information sharing. Share OSHA regulations, incident details, source individual's test results, and employee medical records with the attending physician. Physician report. Obtain a written report from the physician within 15 days. Report should include employee results, infection consequences, and any required follow-up evaluation or treatment. Confidentiality is maintained for unrelated diagnoses or findings. Aseptic techniques. The concept of asepsis is to prevent cross-contamination. All items that are touched with saliva-coated hands must be rendered free of contamination before beginning treatment on the next patient. Rules of aseptic technique. Infection control protocols during dental appointments. During each dental appointment, the following infection control protocols should be observed. Contamination awareness. Remember that whatever is touched is considered contaminated. Minimize direct contact. Directly touch only items that are necessary. Anticipate needs to reduce unnecessary contact. Control contamination methods. A. Clean and sterilize instruments. Ensure dental instruments are cleaned and sterilized. B. Use disposable covers, barriers. Protect surface and non-sterilized equipment with disposable, single-use covers, barriers. Discard covers after each appointment. Apply disposable covers to portable items, e.g., curing lamp handles, amalgam mixers, plastic air-water syringe tips. C. Use protective measures. Use towels, tongs, or plastic bags over gloves for brief handling of equipment or when opening cabinets and drawers for unforeseen needs during setup. D. Scrub and disinfect non-critical surfaces. Scrub and disinfect non-critical surfaces, including countertops that cannot be covered, room door handles, light switches, and other potentially touched areas. Aim to keep these areas as contamination-free as possible with regular cleaning. Preparation of items. Critical items. Definition: instruments that come in direct contact with cut tissues or penetrate tissues. Examples: surgical instruments, scalpel blades, biopsy forceps. Required sterilization: thorough cleaning and sterilization are necessary for use. Semi-critical items attached to the dental unit for reuse. Definition: items that come in contact with mucous membranes or non-intact skin but do not penetrate soft tissues. Examples: dental handpieces, air-water syringes, impression trays. Required sterilization: high-level infection or sterilization is typically recommended for these items. Non-critical items, supporting or environmental. Definition: items that come in contact only with intact skin and do not contact mucous membranes. Examples: X-ray head/cone, blood pressure cuff, countertops. Required disinfection: intermediate level or low-level disinfection is usually sufficient for non-critical items. Sterilization and protection protocols for semi-critical item. Comprehensive measures. Semi-critical items should be subjected to a comprehensive approach. covered, cleaned, sterilized, or discarded. Bacterial persistence. Acknowledge that some bacteria persist even after the use of effective disinfectants. Cleaning and sterilization process. Semi-critical items must be removed for thorough cleaning and subsequent sterilization unless they are designed for single-use, disposable. Use of disposable plastic covers. Semi-critical items, especially air-water syringe tips, can be protected from contamination by using disposable plastic covers. Targeted disinfection. Areas of the dental chair not contaminated by spatter may not need disinfection unless for general housekeeping purposes. Protection for control units and chair backs. Disinfecting time. Application of covers reduces the time needed for disinfecting, optimizing operational efficiency. Ultrasonic cleaning guidelines for sharp instruments. Ultrasonic cleaning is recognized as the safest and most efficient method for cleaning sharp instruments. When used properly, it can be up to 9 times more effective than hand cleaning. Follow these guidelines for effective and safe ultrasonic cleaning. Efficacy and safety of ultrasonic cleaning. Ultrasonic cleaning is considered the safest and most efficient method for cleaning sharp instruments. Effectiveness with proper use. Ultrasonic devices, when functioning properly and used as directed by the manufacturer, can be significantly more effective than hand cleaning. Key features for ultrasonic cleaning devices. The ultrasonic cleaning device should possess the following features. Provide fast and thorough cleaning without causing damage to instruments. Have a lid for containment. Include a well-designed basket. Feature an audible timer for precise cleaning duration. Ultrasonic cleaning procedures observe operating precautions. Adhere to all recommended safety precautions during operation. Optimal solution levels. Operate the tank at 1/2 to 3/4 full of the cleaning solution at all times. Use only cleaning solutions recommended by the manufacturer of the ultrasonic device. Change solutions as directed, with preference given to antimicrobial cleaning solutions. Cleaning time. Operate the ultrasonic cleaner for at least 5 minutes or longer, as directed by the manufacturer, to achieve optimal cleaning. This could translate to approximately 1 minute per instrument. Coating removal. Remove coatings such as plaster, wax, cement, and impression material with an appropriate solvent cleaner. Place the instruments and/or impression trays in a beaker in the ultrasonic device for thorough cleaning. Foil test. Preparation. Remove the basket from the ultrasonic cleaner. Add the cleaning solution to the tank. Degassing. Operate the device for 5 minutes to expel dissolved gases, following the manufacturer's instructions. Measurement. The depth of the solution and the length of the tank. Foil cutting. Cut a sheet of aluminum foil, 1 inch more than the solution depth and 1 inch less than the tank length. Positioning the foil. Submerge the foil vertically in the center of the tank, keeping it 0.5 inches above the bottom. Touching with fingers. Ultrasonic operation. Operate the device for exactly 20 seconds, without allowing the foil edges to touch the tank. Inspection. Inspect the foil closely for small visible indentations or perforations in every 0.5 inch square. Testing uniform. Perform the foil test in the midline, front, and rear areas of the tank to determine uniformity. Documentation. Label foil sheets and file them to document test results. Disposal of clinical waste. Liquid clinical waste. General disposal. Infected blood and other liquid clinical waste, except mercury, silver, or other heavy metals, can be poured down a designated sanitary sewer or drain. Aseptic precautions and cleaning and disinfection around the drain must be performed. Contaminated materials. Items to discard safely. Used masks and gloves. Blood-soaked or saliva-soaked sponges. Blood-soaked or saliva-soaked cotton rolls. Regulations. Follow OSHA regulations for the disposal of sharps and soft waste. OSHA labeling requirements might differ from local protection agency requirements. Pathologic waste. Excised tissues. Require separate disposal. Should not be discarded into regular trash. Medical waste handling. Bagging medical waste. Ensure no injury or direct contact with liquids during bagging. HIV and HBV can survive in wet blood beyond a few days. Sharps disposal. Separate needles and sharps into hard-walled, leak-proof, and sealable containers. Do not mix sharps with soft trash. Regulatory compliance. CDC recommendations. Follow CDC guidelines for waste disposal. Local regulations. Consult local city, county, and state regulations as they may have stricter requirements. Compliance may involve added expenses for stricter management and tracking of waste disposal. Summary. Proper disposal of clinical waste, including liquid waste and contaminated materials, is crucial for maintaining a safe environment. Adhering to OSHA regulations, using appropriate containers for sharps, following local waste disposal laws ensure safety and compliance with health standards. Do's and don'ts of instrument recycling. Do. Wear protective gloves. Use puncture-resistant gloves when handling used instruments. Keep instruments wet. Store instruments in an antibacterial solution before cleaning. Utilize ultrasonic cleaning. Use an ultrasonic cleaning device for effective cleaning. Test and maintain ultrasonic devices. Periodically test and maintain the ultrasonic device for optimal performance. Use quality sterilizer equipment. Ensure the use of good quality sterilizer equipment. Follow operation instructions. Read the operator's manual and adhere to operation instructions for the sterilizer. Annual inspection. Have sterilizers inspected annually, checking gaskets, timer, valves, temperature, and pressure gauges. Use proper water or chemicals. Employ suitable water or chemicals to operate, clean, and maintain the sterilizer. Prepare instruments properly. Place only dry instruments in the sterilizer and use a wrap penetrated by steam or gas. Load sterilizer appropriately. Load the sterilizer loosely, leaving airspace between large packs. Monitor temperature and pressure. Check sterilizer temperature and pressure gauges daily. Implement monitoring system. Utilize a complete sterilizer monitoring system, including daily indicators and weekly spore tests. Maintain records. Keep a record of daily indicators and spore tests. Don't. Use wet instruments. Avoid placing wet instruments into any type of sterilizer unless instructed to do so. Overwrap cloth packs. Do not overwrap cloth packs or use impermeable wraps for steam or chemical vapor pressure sterilization. Use sealed containers. Avoid using closed, non-perforated foil, canisters, or sealed containers in gas or steam sterilizers. Overload sterilizer. Do not overload or cram packs together in the sterilizer. Decrease sterilization time. Do not reduce the required time for sterilization. Interrupt sterilization cycle. Avoid adding instruments to a sterilizer without restarting the cycle. Sterilize viability control strips. Do not sterilize viability control strips supplied with spore tests. Sterilization is defined as killing all forms of life, including the most heat-resistant forms, that is, bacterial spores. The 4 accepted methods of sterilization are as follows. Steam pressure sterilization, autoclave. Chemical vapor pressure sterilization, chemiclave. Dry heat sterilization, dryclave. Ethylene oxide, ATOX, sterilization. Considerations. Each method has specific requirements regarding timing, temperature, packaging, and types of items/materials suitable for sterilization. Commercial modifications may also have specific requirements. Choosing sterilization equipment. Selection criteria: reliable sterilization equipment of the proper size and cycle time, compatible with the practice's needs. Factors to consider. Patient load. Turnaround time for instrument reuse. Size of instrument inventory. Instrument variety and quality. Balancing these factors against the type size of sterilizer selected ensures efficient and effective sterilization in dental practices. Steam pressure sterilization, autoclaving. For a light load of instruments, the time required at 250 degrees Fahrenheit 121 degrees Celsius is a minimum of 15 minutes at 15 pounds of pressure. Time for wrapped instruments can be reduced to 7 minutes if the temperature is increased to approximately 273 degrees Fahrenheit 134 degrees Celsius to give 30 pounds of pressure. Advantages of autoclaving. Rapid and effective sterilization. Autoclaving with steam under pressure is the most rapid and effective method for sterilizing cloth surgical packs and towel packs. Suitability for cloth packs. Cloth packs and towel packs are effectively sterilized through autoclaving, making it a preferred method for processing such items. Automation options. Automated autoclave models are available, offering convenience and efficiency in the sterilization process. However, their performance should be regularly evaluated using a biologic spore test monitoring system. Disadvantages of autoclaving. Temperature sensitivity. Items sensitive to elevated temperatures cannot be autoclaved due to the heat generated during the process. Rust on carbon steel instruments. Autoclaving has the potential to cause rust on carbon steel instruments and burrs, affecting their longevity and performance. Corrosion of diamond instruments and carbide burrs. The steam used in autoclaving may cause corrosion on the steel neck and shank portions of some diamond instruments and carbide burrs. Burrs protection. For autoclave sterilization, burrs can be protected by keeping them submerged in a small amount of 2% sodium nitrite solution. Chemical vapor pressure sterilizers, also known as chemiclaves, operate at 270 degrees Fahrenheit 131 degrees Celsius and 20 pounds of pressure, with a cycle time of approximately 30 minutes. They utilize prescribed chemicals, with newer models handling aldehyde vapors effectively. Edges. Corrosion prevention. Carbon steel and corrosion-sensitive burrs, instruments, and pliers can be sterilized without rust or corrosion. Disadvantages. Temperature sensitivity. Items sensitive to elevated temperatures may be damaged. Packaging requirements. Instruments must be lightly packaged bags provided by the sterilizer manufacturer. Penetration issues. Towels and heavy cloth wrappings of surgical instruments may not be adequately penetrated for sterilization. Monitoring requirements. Routine use of biologic spore test monitoring strips is necessary to confirm heat penetration of heavy packs. Chemical restrictions. Only fluid purchased from the sterilizer manufacturer can be used. Dry instrument loading. Only dry instruments should be loaded, and the door gasket should be checked for leaks to prevent frequent sterilization monitoring failures. Dry heat sterilization. Conventional dry heat ovens. Temperature and time requirements. Sterilization is achieved at temperatures greater than 320 degrees Fahrenheit greater than 160 degrees Celsius, with individual instruments heated at 320 degrees Fahrenheit 160 degrees Celsius 30 minutes. Packaging considerations. Instruments must be placed at least 1 centimeter apart to allow heated air circulation. Total time requirement. Depending on the load and oven efficiency, 60 to 90 minutes may be needed for sterilization. Calibration importance. Careful calibration is necessary to prevent sterilization failures. Short cycle. High-temperature dry heat ovens. Reduced sterilization time. Short-cycle ovens operate at 375 degrees Fahrenheit 190 degrees Celsius, reducing total sterilization time to 6 minutes for unwrapped instruments and 12 minutes for instruments. Calibration imperative. Precise calibration with a pyrometer ensures instruments reach and maintain sterilization temperatures. Advantages of dry heat sterilization. Corrosion prevention. Carbon steel instruments and burrs do not rust, corrode, or lose their temper or cutting edges. Capacity and price. Industrial forced draft hot air ovens offer larger capacity at a reasonable price. Rapid cycles. Rapid cycle possible at high temperatures. Disadvantages of dry heat sterilization. Temperature sensitivity. High temperatures may damage heat-sensitive items. Prolonged cycles. Sterilization cycles are prolonged at lower temperatures. Packaging challenges. Heavy loads, crowding, and heavy wrapping can sterilization. Manual timing, cycles are not automatically timed on some models, leading to potential errors. Calibration and setting errors, inaccurate calibration and improper settings can result in sterilization failures. ETOX sterilization. ETOX sterilization is highly effective for sterilizing complex instruments and delicate materials. Key points about ETOX sterilization include: best for complex instruments, ETOX gas is ideal for sterilizing rotary handpieces and other intricate instruments. Temperature and time, automatic devices operate at elevated temperatures below 100 degrees Celsius, sterilizing items in several hours. Less expensive devices can sterilize overnight at room temperature. Aeration required. Porous and plastic materials absorb gas during sterilization and require aeration for 24 hours or more before safe contact with skin or tissues. Chamber size. Units with larger chamber sizes can hold more instruments per cycle, but are more expensive. Advantages. Ideal for complex instruments and delicate materials. ETOX sterilization is considered the best method for sterilizing complex instruments and delicate materials, ensuring their integrity. Effective for rotary handpieces. It is recognized as the best way to sterilize handpieces, preserving their functionality. Automated devices for efficient sterilization. Automatic devices offer efficient sterilization within several hours, operating at elevated temperatures below 100 degrees Celsius. Cost options for different needs. Less expensive devices are available for operation, providing sterilization at room temperature. Considerations. Aeration requirement for porous and plastic materials. Porous and plastic materials absorb the sterilization gas, requiring aeration for 24 hours or more before they are safe to contact skin or tissues. Chamber size and cost. Units with larger chamber sizes can hold more instruments or packs per cycle, but tend to be more expensive. New methods of sterilization. Investigative sterilization methods, current developments. Microwave sterilization. Challenges. Major limitations for sterilizing metal items. Potential machine damage caused by metal. Inability to reach all sides of instruments. Research efforts. Ongoing research to overcome limitations and improve effectiveness. UV light sterilization. Effectiveness against pathogens. Not highly effective against RNA viruses like HIV. Ineffective against bacterial spores. Limitations. Incomplete exposures of all surfaces. Poor penetration of oil and debris. Limited efficacy against certain pathogens. Potential application. UV irradiation may find use in sanitizing room air to control tuberculosis bacteria. Monitors of sterilization. Sterilization monitoring has 5 components. Mechanical monitoring. 2. Chemical indicator strip in each pack. 3. External sterilization indicator on the outside of each pack. 4. Weekly biologic spore test. Documentation log. Monitors of sterilization. Sterilization monitoring is a crucial aspect of infection control in healthcare settings. The 5 components of sterilization monitoring are designed to ensure the effectiveness of the sterilization process. Here's an overview of each component. Mechanical monitoring. To monitor the mechanical aspects of the sterilizer. Example, checking gauges, temperature, and pressure during the sterilization process. Significance, ensures that the sterilizer is operating under the correct mechanical conditions. Chemical indicator strip in each pack. Purpose, to indicate that the patch has been exposed to the sterilization process. Example, chemical indicator strips change color when exposed to specific sterilization conditions. Significance, provides a visual indication that the items inside the pack have been subjected to the sterilization process. External sterilization indicator outside of each pack. Purpose, to show that the pack has been through the sterilization process. Example, external indicators on packaging change color when exposed to sterilization conditions. Significance, allows quick visual verification that a pack has been sterilized. Weekly biologic spore test. Purpose, to directly assess the killing of highly resistant bacterial spores. Example, using biological indicators, spore strips or ampoules, that contain bacterial spores to challenge the sterilization process. Significance, provides a direct measure of the sterilization process's effectiveness by the system's ability to kill the most resistant microorganisms. Documentation log. Purpose, to maintain a record of sterilization monitoring activities. Example, keeping a log that records dates, results of mechanical monitoring, chemical indicator outcomes, and spore test results. Significance, establishes a traceable history of the sterilization process, aiding in quality control, and ensures compliance with standards and regulations. Dental control unit water systems, oral fluid contamination problems of rotary equipment, especially the high-speed handpiece, involve I. Contamination of handpiece external surfaces and crevices. 2. Turbine chamber contamination that enters the mouth. 3. Water spray retraction, aspiration of oral fluids into the water lines of older dental units. 4. Growth of environmental aquatic bacteria in water lines, and D. Exposure of personnel to spatter and aerosols generated by intraoral use of rotary equipment. It is recommended that dental unit treatment water contain less than 500 CFU per liter of bacteria. Disinfectants, such as an iodophor or diluted sodium hypochlorite, are recommended to clean the system. These disinfectants must be flushed out with clean, boiled or sterile water before using the system. Infection control and making impressions. 1. Precautions. Infection control measures are crucial during impression and bite registration procedures. 2. Universal barrier protection. Personnel should use adequate personal protective equipment, PPE, such as gloves, masks, and appropriate garments to protect against contamination from mucosa, saliva, and blood. 3. Clean, gloved hands. Before making impressions and associated bite registrations, practitioners with clean, gloved hands should dispense materials and disposable items. 4. Wiping material containers. After procedures, wiping material containers with a disinfectant is a satisfactory measure, though least preferred. An EPA-approved tuberculocidal disinfectant is considered suitable for this purpose. 5. Use of custom resin trays. For infection control, custom resin trays used with non-aqueous impression materials are employed once and then discarded. Similarly, stock trays are also used only once and then discarded. Tray sizes are documented in the patient's chart to eliminate the need for further try-ins. Concepts for transporting impressions. 1. Container requirements. Potentially infectious materials must be placed in a container preventing leakage during collection, handling, processing, storage, transport, or shipping to the laboratory. 2. Labeling/color coding. Specimens/containers leaving the facility require labeling or color coding. Controversial choices for transport preparation. Option 1. Send well cleaned, rinsed, and undisinfected. Procedure. Place in a biohazard labeled, heat-sealed, plastic bag. Option 2. Debride, rinse, and adequately disinfect. Procedure. Debride, clean, rinse, and adequately disinfect the item. Place it in a sealed transport bag labeled with the precautions taken. Assume responsibility for the aseptic condition of the item. The dentist or the dental assistant prepares a potentially infectious impression for transport to remote laboratory or to on-site laboratory by rinsing the impression and placing it in a biohazard labeled plastic bag without contaminating the bag's outer. The laboratory disinfects the appliance and then transports it in a heat-sealed bag to the dentist. Prion and sterilization challenges. Overview. Prion are glycoproteins found on cell surfaces. Modified versions of normal prion cause slow-moving, often fatal diseases of the nervous system. Prion are challenging to sterilize in dental offices and have an affinity for stainless steel. Sterilization recommendations. Current WHO recommendations for reprocessing heat-resistant instruments consider the challenge of prion. Keeping instruments moist until decontamination begins is advised, as drying stabilizes the bond of prion to instruments. Methods to address prion. Method 1. Immerse contaminated instruments in 1N sodium hydroxide. Heat in a gravity displacement autoclave at 121 degrees Celsius for 30 minutes. Method 2. Immerse in 1N sodium hydroxide or full-strength bleach, 20,000 m available chlorine, for 1 hour. Rinse, transfer to a dry, open pan, and heat in a gravity displacement autoclave at 121 degrees Celsius for 1 hour. Method 3. Immerse in 1N sodium hydroxide or full-strength bleach for 1 hour. Rinse, transfer dry, open pan, and autoclave in either a gravity displacement autoclave at 121 degrees Celsius or a conventional autoclave at 134 degrees Celsius for 1 hour. Method 4. Immerse and boil in 1N sodium hydroxide for 10 minutes. Method 5. Immerse in 1N sodium hydroxide or full-strength bleach for 1 hour. Rinse and subject to routine sterilization. Method 6. Autoclave at 134 degrees Celsius for 18 minutes. Caution. Prions are resistant to formalin or glutaraldehyde fixative. The described methods aim to provide enhanced protection for both office workers and patients against prion. Steam sterilization of handpieces, autoclave sterilization. Autoclave sterilization is one of the most rapid and effective methods for sterilizing handpieces. Proper cleaning and lubricating procedures, as recommended by the manufacturer, are essential for maintaining the instrument's usefulness with regular autoclaving. Maintenance of fiber optics. Fiber optics in handpieces may experience dimming with repeated heat sterilization over several months to a year. Dimming is attributed to oil residue and debris baked onto the ends of the optical fibers. Prolonging the use of fiber optics can be achieved by cleaning with a detergent solution, wiping the ends of optics with alcohol or other suitable organic solvents. Manufacturers' recommendations. Manufacturers continually improve methods for preparing handpieces for sterilization. Dentists and dental staff should consult the manufacturer for the latest advice and warnings regarding the sterilization-specific handpiece models. Regular maintenance and servicing. Regular maintenance, including proper cleaning and lubrication, is crucial for the longevity and performance of handpieces. When necessary, factory servicing may be required, especially for issues related to fiber optics. Autoclave sterilization of burrs. Protection with sodium nitrite solution. To protect burrs during autoclave sterilization, keep them submerged in a small amount of 2% sodium nitrite solution. Obtain sodium nitrite crystals, not nitrate, from scientific product distributors, chemical suppliers, pharmacies. Sodium nitrite solution preparation. Dissolve 20 grams, 2/3 ounce, of sodium nitrite crystals in 1 liter of purified water. Store the solution in a tightly sealed container for future use. Procedure after ultrasonic cleaning. After ultrasonic burrs, rinse them and place them into a small metal or glass beaker with a perforated lid, e.g., a metal salt shaker. Fill the beaker with sufficient fresh sodium nitrite solution, ensuring the solution level is approximately 1 centimeter above the burrs. Leave the container uncovered or use a perforated cover. Autoclave sterilization. Place the container of burrs and fluid into the autoclave. Operate a normal sterilization cycle. Discarding fluid. Discard the fluid from the container through the perforated lid after the sterilization cycle. Use sterile forceps to transfer the sterilized burrs into a burr holder or tray. Storage. Store the sterilized burrs in a dry environment. Pre-use preparations. Before use, wipe away or rinse off any remaining nitrite residue with clean or sterile water, if desired.